everyone. I'm Dr. Hassan Mubark, rheumatologist from New Zealand, Auckland Regenerative Clinic. Today I'm presenting a case of successful treatment with autologous mesenchymal stem cell therapy for muscle wasting post-surgical repair of Achilles tendon. A little bit about the background of Achilles tendon rupture. It is easy to diagnose by clinical examination, but ultrasound scan enable us to rapid bedside confirmation of the diagnosis, and MRI provides more anatomic details with the greater accuracy and looking for other pathologies like calcifications in the tendon, tendinitis, enthesitis, or other pathologies. Usually the management of acute AT rupture, initial management is comprises of rest, anti-inflammatory medications, and ankle immobilization. With a surgical repair, reduce the risk of recurrent AT rupture comparing with conservative management. Operational treatment is deemed in a significantly higher complication rate than conventional therapy. The increased complication risk may be associated with open repair surgery. About 80% of athletes can return to sports following AT rupture. In the management of chronic AT rupture is with the use of flexor hallucis tendon transfer is a good option with favorable outcome comparing to directly stitching the tendon. Despite an excellent surgical approach with the long-term complications of scarring and some limitations of achieving competitive sports comparing to pre-rupture status cannot be avoidable. There is growing evidence that mesenchymal stem cell therapy can improve the tendon's function and repair. This case has been treated under our clinic, a 44-year-old female who works as a development planner, usually fit and healthy, and she ruptured her left Achilles tendon in 2012 when she was playing netball. She felt as if someone kicked her in the back of her leg, and she was treated conservatively, followed by moon boot, and then weight bearing, followed by weight bearing for 3 months, for 2 to 3 months, and physiotherapy has helped her recovery. Around 5 months following the original rupture, she felt a slight pull in her Achilles tendon with non-painful limp, so she did not do much about it. And a repeat ultrasound in the community revealed Achilles tendon functionally ruptured with disorganized scar tissues in the tendon gap, and this is counted as a chronic AT rupture. This is how it looks like on MRI. As you can see on the arrow, there is a disruption of the tendon continuity and a complete rupture of the distal tendo-Achilles with some thickening of the myotendinous junction and surrounding edema within the soleus muscle. The surgeon felt in that time was difficult to stitch together the ruptured Achilles tendon, and he has chosen reconstruction to reduce the Achilles scar, and he took a flexor hallucis longus tendon transfer back in November 2012, and followed by several years of rehabilitation program, and she was committed to that. Despite that, she developed calf muscle wasting and weakness together with atrophy. In June 2020, the orthopedic surgeon noted the calf muscles were weak and atrophied, and she could not perform a single heel raise. With a foot and ankle disability index score of 74 and a follow-up MRI scan showed remodeling of the left tendon Achilles with surgical changes at the reconstruction site. As you can see, the double arrows show some tendinopathy post-surgical changes in the distal tendon Achilles and soleus tendon insertion zones. And this also showed a partial thickness tear at the soleus musculotendinous junction. In August 2020, she approached us to assess for regenerative therapy as an experimental treatment which we can offer in New Zealand. And our findings were post-surgery mid-calf scar with soleus muscle wasting at the tendomuscular junction. And once again, she could not perform heel raise. And she was concerned about her inability to carry out recreative sport or running. After discussion pros and cons of mesenchymal stem cell therapy, she elected to proceed with this. This is before stem cell implantation. As you can see, there is a scarring, wasting, muscle atrophy, and inflammatory swelling and changes. The harvest and the lab part is as follows. She had abdominal fat taken, 53 grams, adipose tissues. This was harvested by a qualified general surgeon and follow the following protocol. The lipoaspirate was washed and then digested with collagenases, and we got the stromal vascular fraction called SVF was separated from the digested adipose tissues through density centrifugation, and this was plated in a culture media DMEM and 10% of HPL to expand the mesenchymal stem cell population. The cells were grown to 90% confluence over 8 weeks and then cryopreserved until the injection and implantation date. The implants got prepared on the date of the treatment, and the cells were washed and filtered before being resuspended in Hartmann solution with 10% human platelet lysate, which is the HPL, in syringes for administration. Cell count was measured manually and confirmed by hemocytometer, and the viability test was calculated by trypan, a blue exclusion dye, and the viability was 95 to 98%. The MSC implantation on 16th of December 2020, we performed the stem cell injections after informed consent and explained the procedure fully. Under complete aseptic technique, we used 100 by 10 power 6 of mesenchymal stem cells combined with PRP. The total amount was 10 ml volume. 8 ml of them was PRP, and 2 ml was the mesenchymal stem cell volume. The PRP was used was prepared by using ACDA tubes without gel and placed in centrifuge for 8 minutes. We added the PRP to the expanded stem cells. Total amount of 10 ml. We injected the solution in multiple areas of the soleus Achilles junction under ultrasound guidance using 1.5 inch 25 gauge needle. So this is like small size and does not affect the viability or the function of the stem cells. The injectate was distributed in a fan-shaped fashion, penetrating the scar tissues, moving in multi-directional approach. The outcome, 6 months post the stem cell implant, she reported a positive outcome clinically, with the hair raise started got positive. This means she was able to do the hair raise, in which, as you recall, from 2012 till 2020, she was not able to perform that. And then she started to run slowly, and that's something new for her. There was improvement of the foot and ankle disability index score from 73 to 91.3. And MRI scan revealed an increased heterogeneous signal within the distal Achilles tendon. This has been discussed with the radiologist and suggested this is an inflammatory healing stage. While the patient reported a positive clinical outcome, indicate those post-implantation inflammatory changes are part of the healing process. And there was a stable atrophy and intramuscular edema within the calf, together with a slight increase in edema signal at the distal myotendinous junction of the soleus. This is 6 months after the implantation of the mesenchymal stem cells. As you can see, she is able to perform heel raise, and the left calf muscles looks tighter and less swollen. Suggests there is a muscle contraction and ability to function in a much better way. This is to compare before and after. As you can see on the left side, where the arrow and the previous scar is, the tendon was atrophied with more scarring and wasting associated with some swelling suggestive of inflammation. This has been reported 6 months post the injection. I repeat the video. As you can see, the left leg is able to do the heel raise and good contraction. Our discussion about this case, some studies showed aggressive surgical intervention was the preferred option over conservative management, based on early finding that conventional treatment is associated with high re-rupture rates. So surgery is an appropriate option for a repetitive or chronic tendon rupture, Achilles tendon rupture, particularly in sport individuals. Regardless of the treatment modalities, aggressive early rehabilitation is advocated to acute Achilles tendon rupture to allow for an early return to activities of daily living with high patient satisfaction and functional improvement. There is a growing interest in providing biological stimuli to heighten the tendon reparative response. Mesenchymal stem cells are promising science, as they have the potential to provide an appropriate cellular signal to promote a new tendon formation called neotendon during repair rather than scar tissue formation. This is currently being studied in various research facilities and clinical practices to ascertain efficacy and safety. We believe the superb outcome in our patient could be related to a high number of mesenchymal stem cells combined with the platelet-rich plasma in the same syringe to have a synergistic effect and implanted appropriately under ultrasound guidance with multidirectional approach to cover various depths of the Achilles muscular junction. The FADI score rose from 74 to 91.3, suggest improvement mainly came up to her toes and doing complex works. And the MRI finding of increased signal 6 months post-treatment could be a good sign of healing. But this is worth repeating in the future to see the progress with MRI findings. We propose a future randomized control trial to test this therapy and standardize the technique used to have consistent results. Conflict of interest, none. These are the references. Thank you for your kind attention. I am Dr. Hassan Mubark from Auckland Regenerative Clinic, rheumatologist practicing in New Zealand. Thank you.